Right, so I'm going to do just a really quick role of the pharmacist. I'm the senior lead pharmacist for neuro at Barts Health, so I work with Gavin and the team, some of who are here. But first, a lot of people have mentioned, so yesterday they're getting emails from patients about cannabis and the legislation change, and it's been on the news everywhere about how things have changed. But actually nothing's changed at the same time. So although the Home Office might have changed the legislative status of cannabis, there's no new licensed product. Sativex is still available as it was last week, so there's no change to the commissioning status. For individual patients, you might have local approval, and an unlicensed product still might need to be sourced by your pharmacy and priced. NICE guidance is due next year, but we plan on sending a patient information leaflet that everyone can use and adapt to send out to patients so they understand the communication that's gone out and everything, because we do realise this is a national problem, and it's not, although all the communication, there's some stuff on MS, a lot of things is on sickness and pain and other areas. So we do hope to help you solve some of the emails that I know you're all getting. Obviously, that was only added. So what I'm actually talking about is variance in terms of neuropharmacists. So there are different levels of pharmacist cover amongst all of your centres. So there are some centres that have 8C consultant pharmacists on board or coming on board, and then some which will have a named bit of a pharmacist who you go to when you need to order a drug or covers your outpatient clinics, and it's not even the same person. There's variance in job plans and what's covered, and there's differing bandings from band 6 up to band 8C. So we did a survey of people that would call themselves a neuropharmacist, and we got 20 responses in 2016. We now think we would get more than that if we redid it. 65% of those people are full-time, working full-time, but the average time spent on neurosciences was only 59%, so most of us cover a bit of something else. And the average time spent on MS is 27%. 13% of the people actually prescribed DMTs, but most people, 82%, were screening DMT prescriptions. And I'm sure that percentage will go up massively now, because you think 2016 was a long time ago in the world of DMTs. So we have a UK Neurosciences pharmacist group, and a lot of the committee members are actually in the room. And what we've offered is network and support. So before this, to be a neuropharmacist, you just had to be in a job that somebody, your chief pharmacist, decided, oh, you cover neurology, you could be the neuropharmacist. And then you were a sole worker and you didn't speak to anyone, you spoke to a neurologist, so you just learned from your own team. You didn't learn that people did things differently. I thought everyone used cladribine subcut. And then we just started complaining at each other. And then I think one of the pharma companies came and they said, oh, I'm meeting such and such pharmacists from this place. And I'm like, who are they? Why don't I know who they are? And then we've now got email forums, we have national and local meetings, we share best practice and protocols, we avoid that duplication of effort, which the NHS is so good at. We problem solve. We're creating a training program with the RPS, so our Royal College, or our professional body, to look at how you can accredit yourself against MS, the hope being that this can then be used again for other professions. We have a role in policy development consultation, and we currently cover over 20 trusts in the UK. We're running masterclasses with the UKCPA for very junior pharmacists who don't know, they know where the brain is and that's about it, to learn from senior pharmacists, but with the Neuro Academy we're learning to train more senior pharmacists. We also deal with out-of-stock drug queries and share across local trusts. So especially, I work in London, for the trusts across London, we can often just pick up the phone to a friend or a colleague and saying, can I borrow X, Y, Z? Do you have any, because our delivery didn't arrive? And you'd be surprised at how commonly that occurs. But you guys don't hear about it because we solve it behind the scenes. And we are auditing what the role of what pharmacist does within teams. And what we should be doing is asking you guys, what would you wish we did do? And obviously, it's going to be some of the stuff that we've heard before about limiting the variance, looking at where we all have capacity issues. So we've been included in the MDT in national documents, and we're a role. We have expertise in medication. We can look at patients' comorbidities, contraindications, renal, liver function, to see what patients are suitable for drugs. We do have a specific role within the MDT. So what takes up our time? So there's population-based work, so we often are involved in writing the protocols for the DMTs, including lines of responsibility. So I think everyone's very good at saying, oh, we'll use this drug and the XYZ needs monitoring, but unless we define who's doing the monitoring, I think there's lots of duplication of effort. So I think as a community, we need to avoid all this duplication of effort. We do business cases for non-commissioned drugs, finance queries. I have to sit with the head of finance for our trust now once a month to go through the MS spend. So I could go and say, oh, go and speak to Gavin, go and speak to Klaus, but actually I can answer those queries. And they just want to know, are we going to get the money back? And the answer is every time, yes, we do. But because it's high spend, they just want to sit down once a month. It takes 10 minutes, so it's fine. At Barts Health, we spent around £10 million on neuroscience medication, and 81% of that is on MS drugs. So that's why our division really care about the MS drugs. We're also looking at cost savings and sequin work. So biosimilars have been mentioned and generics where appropriate. As a community, biosimilars are coming. They're going to come and hit us all. But when they come and they become more cost effective, maybe we should be going back to NICE and saying, can we redo the cost effectiveness analysis? Can we open it up to be used in more patients? So they do open opportunities to allow that investment to come back into our own service, and generic drugs where appropriate. The patient-specific work, MDT, so I've mentioned what we offer in the MDT. Some of it's just virtually MDT or attendance at the meetings, funding for patients or for new patients on DMTs. My trust, I complete Bluteq forms, so I log on and complete them. I know that's unique, and most of the pharmacists don't, and the people, but all pharmacists will be checking that people have the Bluteq forms completed, ensuring trusts have access to the correct Bluteq forms. So Bluteq can be the forms can be switched on for certain trusts. So if you might not be able to see, say, the alemtuzumab form because it's not been switched on. So often we work behind the scenes to make sure that the correct forms are switched on. DMT prescribing, including monitoring's occurred, home care renewals and problems, and the Hackett report, which is national guidance, say that all home care prescriptions should be coming through a pharmacy department. Now, in all trusts, that isn't happening, but at some point, your chief pharmacist should be involved in your process and at least be aware that you're doing home care at least. DMT monitoring and the day case infusion orders. So the NHS England commissioning pharmacist. So previously to NHS England existing, there was one clinical commissioning pharmacist in the Midlands, and then they came into London in 2013. And for London, it was the 11 trusts with the highest spend on NHSE drugs. So they just wanted to look at the drugs. And then they were called at that time the medicines optimization leads embedded, and hence the term MOLE came out, which probably wasn't so great for them. So they then have rebranded themselves. And what they did was look at the NHSE spend at the trust, budget forecasting, any savings projects, commissioning queries like from NHS England, what are we being billed for from the trust, can we bill for that, and looking at what we send, the data we send, and NICE compliance and Bluteq. The idea being in 2012 that they would work across the patch, they wouldn't just work in their trust, they would go to local trusts that didn't have an embedded pharmacist and help them out. But everyone became too busy because they were dealing with the 11 biggest trusts. They didn't have time to go anywhere else. So actually the behaviour hasn't spread out. The IVIG model, when we get the national and the local regional IVIG panels, they will be stricter in how that works because they will want that to be spread. So some of you in the room will be involved in your IVIG regional panels. So that roles will be different. So my personal wish list, and I am literally rushing through this because I know there's comments from my talk and previous talks, is I wish that we could register all patients on a DMT onto Bluteq, whether that's commissioned, a trial patient, or it's trust funded, and that's probably just us. But I think we need to have a picture of all patients on DMT across the country. Easy to produce reports at trust level, which everyone's said. Allow benchmarking at a local level, so between different consultants, but also between different trusts. So that'd be useful. Ease of switching trusts on Bluteq. So if a patient moves around the country and goes to different trusts, there's no box to tick saying patient was on a previous DMT from another trust. That would just make life easier. The EDSS score, I just think we need to say subcategories of how it was measured. Is it self-reported like patient reported it, clinician measured, or clinician guesstimate? That would be quite useful. And automation of monitoring. So NHS-wide, not trust-specific. We hear examples of where trusts have got their own automated monitoring systems that can tell you this patient's blood tests are overdue, but actually it needs to talk to the whole NHS, not just your little bit of it. Because somebody might see a neurologist in your centre, and then that same patient might go in and see another speciality at a neighbouring centre. Are they having their blood test duplicated for no reason? It doesn't seem to make any sense. And I have one of my objectives is set by the MS team at my trust. That should happen across the board. So all of you will have access to a pharmacist, I'm hoping, at some level. You should be saying to your chief pharmacist or your pharmacist boss and saying, can we set one objective to get them to be integrated into your team and also to help you with your workload? Because there's no point all this duplication of effort. So I think one of the biggest variants that causes is capacity. So when you look in March 2013, at Barts Health, we had 278 patients on DMTs, and in May 2018, we had close to 1,000. We haven't grown that much in our capacity at any level, from MS nurse to coordinators to pharmacists to consultants. No, we haven't gained that capacity. And actually, it's a change in the newer drugs that require more monitoring, that are more complicated, that is actually growing exponentially. And actually, it's the capacity issues, which is why we have to work differently. And that, I'm done.
It's quite clear from Joela's presentation that the pharmacist is an intricate part of this initiative, because they have data and they have access to data that the rest of us don't have. So that's fantastic. I think it's about the first meeting I've actually been to like this where a pharmacist has been on stage. So it's good. Any questions for Joela? No questions. Oh, there's a question over there. Ariana?
Well, it would be a really interesting idea to get our pharmacists involved with filling in the Bluteq forms. And
I'm not promising that. I've been told I cannot promise that pharmacists will fill them in.
Could you, just from your experience, try and outline, are there any difficulties you have doing it as opposed to the MS nurse? Have you noticed something, some shortcomings, some information that's lacking, or some lack of confidence in some area by doing this, so I'll be alerted to it?
A lot of the information is already in the electronic notes. So, it's all available there, so it's just searching through it. The reason I do it is that otherwise, so Gavin can say to a patient, you start on this drug, and then an MS nurse will then decide the drug, and then all the information's on the system. Then before supplying the drug, I'm meant to check, has the Bluteq form been filled in? And I just felt there's a lot of duplication of loops there, so it was to reduce that. But that's because it works in our centre. I am not promising all pharmacists will fill Bluteq forms in.
Mariana?
May I ask you, please, the protocols, the DMT protocols, are they the same in all trusts, or there is a variance between trusts?
A lot of trusts, there's local variant, just because on the staffing you have. So you have to make them local, otherwise you just use the SPC. Yeah. So we'll put on who's doing each role in the protocol as well.
I think the message though is that these things are you don't have to reinvent any wheel. You just have a little email, and people will prepare to share their protocols. If they're not part of the team. Question over there.
Starunyaran from Coventry. So a lot of us who use immunotherapy for other neuroinflammatory conditions know that there's this shared care protocol arrangement with general practice. And I think someone brought up earlier about the fact that GPs need to be more engaged, and more so with DMTs because of the compliance, obviously, being higher if GPs are engaged with patients and patients with doctors and sort of in hospital doctors. So do you have experience in sort of shared care protocols with DMTs and GPs and MS practice?
The problem with the DMT shared care is where the funding streams lie. So they just feel like we don't pay for these, we don't get anything involved in these, we're not touching them. But it's when patients are on other drugs that you might be able to tie them in. It does depend on individual GPs. Our local CCGs hate shared care and want to get rid of all of them and say, send it all back to the hospital. We have reminded them of the NHS Constitution and saying, actually, care closer to home is what we should all be aiming for. And actually, a patient coming to the hospital for a blood test is not care closer to home. So it's individual CCG conversations. We haven't cracked it at all.
It's just a comment rather than a question. So we were that close to having a neuropharmacist, and then she left. But my absolutely fantastic admin team do all our Bluteq forms, and they've got it absolutely nailed. It comes out of largely out of the MDT, and I think it demonstrates that how important having a strong, well-led and broad admin team are, and how much they can help our clinical practice. And I guess it's just one of the ways that what we've heard a lot of in the last day and a half is the way that we have to change the way we do things to solve some of the problems. And I think the admin team are absolutely key.
Okay, we're going to move on to the next one.
Cool.
So, Professor Robin, thanks, Joela.